are not subsistence farmers, but 142,000 farmers that are subsistence farmers. That means that the majority of farming households in Meru County are subsistence farming households. Does it make sense? So I have a question for you about these data. What do these statistics have in common? I can go back if you like. What do they share in common? Any guesses? They all reflect experiences of people in the real world. They're all about the population, the community. We can become so caught up in statistics, in sectors, in domains, and departments that we lose sight of the people who experience challenges in an overlapping way. We can become so defined by the statistics that we're looking at, the department where we are, the domain in which we're thinking, that we forget that these all overlap within the broader community and population. Our own work in Kenya in 2012 began when Stanley Guattari asked me, what do we do about children who live on the streets? At that time, I was just beginning my doctorate of public health, and I thought, I don't know, let's look at the peer-reviewed literature. And in the literature, there was lots on what children who live on the streets experienced on the streets, forms of abuse, substance use, violence, out of school, failure to thrive, these things. Some of what they experienced before they went to the streets. But out of the tens of millions of kids who live on the street globally, there was no research, none, on what to actually do to help kids who lived on the streets. And that really made me unhappy. So we started on a research trajectory that I'll talk a little bit about here, and then I'll talk a bit about, we'll come back to the data that I showed before and the areas where you think about health and social wellness and what this all might mean for you. So we did qualitative research. We did some focus groups with communities that had kids who had gone to the street. And we asked them, why would a kid leave home? And they told us things about the kids. Maybe the kid feels inferior or has a learning challenge. They told us things about relationships between the kids and their parents, like maybe their parents are abusive or negligent. They talked about things between the parents and within the parents, like the parents might use more substances or have more partner violence, intimate partner violence. Things about the community, maybe the community has more early marriage, gender inequality, FGM, sexual abuse. And then there's the larger environment of low economic development, and they even mentioned climate change. So this was a very sophisticated understanding of a single question about kids who are on the streets. Since that time, we've looked at this. If you want to look at the peer-reviewed publication, you can scan this QR code. We have the first published multi-level longitudinal look at reasons that kids go to the streets. And we found that the survey data that we had from this verified, validated what the community had told us before. That where communities experience and where parents experience less collective efficacy, a sense of we can do this together, lower social support, when they don't have the support of an intimate partner, their kids are more likely to go to the streets. We looked at psychological predictors. This is too small. So if you want to look at this in detail, you can go back to the peer-reviewed publication that I mentioned. But we found that guardians who had less psychological flexibility, like less mental coping ability, less positive emotion, lower self-compassion, like concern and regard for themselves that was kind and generous, lower social curiosity, lower joyous curiosity, higher depression, and lower meaning in life, all predicted the risk that their kid would migrate to the street in the future. And we asked them about their childhood experiences, and where guardians reported more positive childhood experiences, like when they were a kid, they had the ability to talk about their feelings, they had family support during hard time, they were supported by friends and by other adults. All of these things were protective. When people told us at one time period that they had more of these as a child, the risk that their kid went to the street later was lower. And similarly, where guardians had reported more adverse child experiences, particularly physical abuse, they had a higher risk of their kid going to the street. So we see this intergenerational pattern. And then, of course, parenting styles. So where there's more childhood maltreatment and less positive parenting, there's a higher risk of kids going to the street. And this was interesting because most of the literature, when it was trying to, of the peer-reviewed literature, when it's trying to understand why kids are on the street, they would only look at wealth, like their parents are low income, and they would look at parenting practices, like the kids reported that they had experienced violence at home. But what we found in our data was that these particularly economic factors were not the leading factors contributing to kids being on the street. It was social connection or social disconnection, mental poor health, and dissolution of relationships between adults and poor relationships between parents and kids. So this is really helpful and is validating for what we are trying to do with the model that I'll talk about in a second. But also interesting, we found that there was geographic clustering. We had 20 villages in our study, and 5 villages, explained half of the new cases of kids going to the streets. That is, if you take 20 villages, the risk that a kid is going to migrate from this village or that village is not the same. There is a clustering of risk in these 5 villages compared to the other 15. Are you with me? And so we wanted to know what's the difference between these 5 villages and the other 15 villages. And so we took out everyone who said they had a kid who lived on the street, and we looked at other people's social, mental, economic well-being. And what we found is that in villages that had higher risk of their kids going to the street, they had collectively more depression, less social curiosity, lower collective efficacy, less compassion for themselves. So the picture is that it takes a village to raise a kid. And if that village is more depressed and less interested in investing in their relationships, has less hope for what they can achieve together, then the risk of other people's kids in that village is higher. Does that make sense? So the model that we developed is like Yuri Bronfenbrenner's socio-ecological model. If you want to think about what happens to a kid, you can ask questions about that child. But also, you need to ask questions about the family system, questions about the parents' economic and social well-being, questions about the neighborhood and the village where that child is raised, questions about the national system, even county system, and then questions about the global and temporal systems. So if you want to think about a kid who lives on the street, you need to understand that it's not just the child, it's not just the family, it's not just the neighborhood. There are multiple levels in the socio-ecological model that come to bear in the risk of that kid moving to the streets. Sinisawa, we good? All right. So the question that drove us from 2012, what do we do about the kids who live on the street? We knew from our data that we needed a holistic, reintegration-oriented model because kids were saying, I don't want to be in the street, I want to be with community. We knew that the kids who were on the streets had a lot of trauma, so we needed trauma recovery. We needed to work to facilitate sustainable community-driven growth in communities where we focused. And we needed to develop a novel intervention for in science of social system transformation that looked at these multiple levels. So the program that we developed and the model that we used to explain it, the model is called the Flourishing Community Model. We have the Watoto Wahari Rescue Center, where we have social work team that focus on developing rapport with kids on the street and helping them find their way off the street. And we have what we call Kuja Pamoja kwa Jamii, which is a community transformation model that I'll talk about more in detail. So this is an image. This is Patrick. Just to put some humanity into this slideshow, this is what Patrick looked like in 2013 and in 2020. At the farm, they learn skills like how to take care of animals and how to grow crops and how to take care of themselves and how to take care of the building where they live, their dormitory, how to go back to school and be successful in school academically. And what we found, this QR code goes to this publication. We have the first quantitatively assessed, validated model for reintegrating children who live on the street anywhere in the world. And what we found is that it's more likely that kids go to their families and stay in their families when their families are in the KPJ program. And I'll talk about that in a second. So since we started in 2016 and eventually we've helped over 500 kids find their way off the streets. The first peer-reviewed support for reintegrating street-involved children and youth in any LMIC. And then learning that when we involve parents and communities, reintegration outcomes are better for children and youth. So what is KPJ? We had in February a 2-hour masterclass on the flourishing community model. And I don't have time to go in depth into it too much. But I'm happy to talk about it later, and we have plenty of peer-reviewed publications for your consideration. But we begin with the Village Savings and Lending Association. We go to the family of the kid who we found on the streets, and we invite them to form a lending group where people develop economic and social resources together. So they lend money to each other, and we found that to be quite effective. We have some modifications to it. But after about 4 to 6 months, we invite these groups to develop what we call a parliamentary committee, which is a committee of people who are participating in the program, who are helping other groups form, and helping resolve conflict and misunderstandings within each group at the village level. We developed a positive psychology curriculum we call Pathways to Flourishing. You can QR code that. And resource committees. So within villages, we have between 400 to 1,000 people, sometimes over 1,000 families that meet. And this means that there's a whole wide range of things that they care about economically, with respect to agriculture, food production, mental health, really anything that matters to a community. If it matters to a few people, we can organize a resource committee where they can learn together and be kind of train the trainers and bring new information and perspective back to the community. So when we talk about flourishing communities, we often, in clinical practice, we just think about resilient individuals. We want individuals to get back to where they were before they took some challenge. And resilience is always defined by the threat or the risk. You're coming back from something. But flourishing individuals means that you're defined by your response to an opportunity, not just to a challenge. So when you see opportunities, what's your ability to move towards it and to build something that's meaningful? And that's at the individual level. When we think about resilient communities, we think about communities that took some challenge and bounced back to where they were, close to where they were before that challenge. But when we talk about flourishing communities, we talk about the capacity of communities to respond to opportunities that are consistent with what they care about, that aren't defined by a risk or a challenge. Does that make sense? So this is the flourishing community model tree. It's a metaphor that we use to help train people who participate and then lead the program from within the communities and villages. Phase 1 is inclusion and reconciliation. So we use kids who are on the street to tell us where there is distress in a community. We've also used where people are recruited with HIV, because we know HIV is a challenge across multiple sectors. But there's other indicators we can think about to tell us where people need to have more particular focus and attention interventionally from us in order to support their holistic well-being. So phase 1 is inclusion reconciliation. Phase 2, I mentioned that the Village Savings and Lending Association, or a modified version of that, is what we use to build the community self-organization. And we found with time, and as I'll show you in the data later, that income, wealth, social support, collective efficacy, these things increase. And this is a globally known byproduct of Village Savings and Lending Associations. Phase 3, improving mental health and psychological coping. So we talk about the roots being inclusion and reconciliation. We talk about the tree trunk, the structure being building economic and social resources together. Then we talk about mental health as what's required to take the assets, the resources that people bring to a community and move them to a place where they can grow. People who have more depression and anxiety and PTSD find it harder to grow and move in ways that are meaningful to them. So improving mental health is like improving the sap that allows the nutrients to go up and also the energy from the sun to come down and the whole system to grow. Then we talk about phase 4, the sector-specific growth. So when you have in a village 1,000 families that are meeting, they each care about their own thing, something that they care about, and they can get together with other families and improve that. So we have resource committees in early childhood development and maternal child health, in farming and agriculture, in water governance, in HIV prevention. You know, anything that a community might care about, you can mobilize to build their leadership around that. And we talk about how leaves bring life and energy to a tree. Sometimes it's something outside of a community that's required to bring energy and life and growth to that community. We talk about flowers, how flowers are attract pollinators. Sometimes there has to be something that changes within your community in order to continue growing. But as that happens, you find that you produce fruit. That is, there's something good and identifiable that's nutritious and valuable now, and a seed. You're creating something that perpetuates intergenerationally. So that's the flourishing community model, and I'll show you some data around it. For those of you who might be more behaviorally oriented and like a good theory to explain what's happening, you can't see there at the top because of the projector, I guess, but at the top is trust and shared trust and identity. The first place where we started, they told us 4 months after they started, we used to not be able to talk about violence in our families, but now we trust each other enough that we can do that. And not only do they talk about violence in their families, they find ways to prevent violence in their families, ways to show up for each other that helps improve the things that now they're able to talk about. So we'll talk about shared trust and identity, engagement, so discussion around it, collective education, shared learning, like what are you doing about this, what am I doing about this? It just happens naturally when people come together routinely. And then mobilization. So this looks like it might be a success, this might be helpful, this might be useful, let's try this. So they do it, and then they assess, did it help, did it get where we wanted to go, and if so, how do we sustain that improvement over time? Village level diffusion, I talked about parliamentary committees. So these like orange clusters you can think about as the internal lending groups that come together once a week. And they nominate members to be a part of the parliamentary committee in their village, which you can think about as like the pink color, and the green color is like a resource committee. So it's a way of organizing the social network within a village where you have between hundreds and 1,000 people meeting every week. And it's helpful, it's useful for diffusion of innovation. And then this is the social capital and information, motivation, and behavioral skills model. So where you experience belonging, where you feel like you can trust people, what matters to them is going to start mattering to you. And if interventionally you're creating a place where people belong and see and care about each other and have shared concern for each other, like happens in an internal lending model, then you can begin engaging the norms that drive their behaviors related to any behavior that you want. Creating a context to engage with those norms, to then drive information that they have about it, to then support behavioral skills and competence, sense of self-efficacy that they have. And then motivation. It's hard to stay motivated if you feel like nobody cares about you. But when you know people care about you and you show up for them and they show up for you, motivation goes way high. So those two things, information and motivation, drive behavioral skills and practice in the behavior, and all of that drives the behavioral outcomes. So if that's positive parenting, if that's adherence to ARTs, if that's whatever the behavior is, some version of this model is likely going to be there explaining some of the behavioral outcomes. So impact. This QR code goes to a collection of peer-reviewed articles that are in a Google Drive if you want to access them. And what we've seen over time is since February 2017, we've grown from 0 families in the program to now over 15,000 families, including 1,000 men in a particular like KPJ men's group. So we've seen, and this is across 72 villages, mostly in the game base, and some in other parts of Meru and some in Tarakanidi County. And the data that we have show that loneliness decreases, a sense of belonging increases, This is income over time. So we find that, like, on average, we pay about $10, I think about, in terms of dollars, about $10 a year per family. And after 12 months of being in the program, the average increased income is more than $10 per month. So it looks to us like the best data we have, that for every $1 or 1,000 shillings we put in, there's a 12-fold return only in just looking at the income, increased income at the household level. We also see wealth increases, food insecurity, water insecurity decrease. There's improvement in collective efficacy, a sense of we can do this together, improvement in social support. These are all significant at a P less than 0.05. By the way, we see improvements in depression, in anxiety, a decreased feeling of being stuck where you are, an increased ability to imagine something new for yourself, increased social curiosity, increased meaning in life, decreased HIV stigma, increased ART adherence, self-efficacy among people with HIV, increased uptake of ever being tested for HIV, decreased intimate partner violence, increased intimate partner cooperation, decreased child maltreatment behaviors. So when we think about community-led transformation across a number of sectors, we find in the FCM hope for thinking about doing that at scale. And then sharing the benefits of growth. So people report having more political influence and more social influence after being in the program for a while, which tells us they're telling their stories. So that's the flourishing community model as we've developed it here in the US. When we're here in Kenya, when we're in the US, we're asking the question, how do we support the insights and scale the network, the impact of insights that we've gained from the work here? How do we do that digitally? How do we do that in the US? And that led to the development of this company called Flourish. So we have built the digital tools to mobilize health and social data to identify where people have higher risk, and then to engage with them and focus with them to try to improve their economic and social well-being. We have the digital capacity to support recruitment, enrollment, and track participation, to deliver mobily through like a smartphone, psychological support to improve mental health, to improve provider training and support provider linkages digitally, training for patients, for communities, for community health workers, and clinical-based providers, and then capturing and sharing stories of transformation. So this is how we think about mobilizing data within that paradigm. There's a lot of data that's stored places. I was talking about the villages where kids come from being a part of how we think about where we need to focus. But if you had data from a dispensary or from a health clinic or from a school, from all of the schools, all the primary schools, all the secondary schools in a location, you could mobilize those data and say, here we have more challenges. So using those data to enable community engagement, to support community empowerment by having that information that then can lead to improved decisions, lead to change that's being affected, and have that be sustained as part of an ecosystem that is supported and enhanced digitally. If you wanted to QR code this, this goes to some of our digital tools. Really, we siphoned off some of the tools that we've developed just for this conference. But here, this map obviously is Meru County, and we have the sublocations, sublocations and outline. And you can see each sublocation is filled in with a different color. Think about the health concern that you have. Like, what is it that concerns you about people's health? Probably that is not homogeneously distributed across the population. There's probably some villages with more and some villages with less. How would you think about leveraging or mobilizing where people have the health concern that you have in order to inform a more specific, targeted, precision community health intervention? This is to the chatbot that we created. It's in Swahili. This one, we have a version in Swahili, but the more robust version that's more complete is in English, where you'll get a warm welcome and some identification of what you want to focus on that could take you to medical information, to diet and nutrition information, to resources available within your community. So maybe it's like some support for pediatric disability or for cancer screening or whatever you want to know about. Mental fitness support, and then behavioral promotion. So right now we have physical exercise in it, but we're building in positive parenting too. So think about your health concern. How might the ability to deliver information relevant to that concern en masse, like to a lot of people at once, help promote people's health? Thinking about the data that are available within Kenya, the Kenya National Bureau of Statistics, Ministry of Health, KIMRI, Wellcome Trust has data. There's food insecurity data, humanitarian data exchange, social protection, social protection data, health facility list, World Bank has data, and there's other data stores that I don't know about. But mostly, those data go and they sit in some place, and they're not mobilized to inform where we have our intervention and what that intervention looks like in the locations where we're intervening. Which brings up for me the big questions. What if we mobilized existing data from all possible sources to inform village-level interventions? What if we implemented the flourishing community model in these locations to develop communal capacity to respond to locally prioritized challenges? What if we adapted the chatbot, Vitality Hub, to help community leaders and residents understand the challenges they face and help to best respond to these challenges? How might these actions improve well-being? And how might we know? How might we register that it's having impacts? And then what if we repeated this cycle until all villages in Meru County, all villages in Kenya had optimal health and well-being? This is the big view that we have, combining the possibilities of data, innovations and integrations, and the flourishing community model. Thank you.
Professor Goodman, for the good presentation that you have shared with us. And let us appreciate Professor Goodman again. Good, because we don't have a lot of time. We will open this presentation for only 2 or 3 questions before we can move to the next keynote address. So I open the floor for anybody who may be having a burning question. Yes, there is a check.
Thank you, Prof, for the very, very insightful presentation. Mine, I just have 2 questions. One would be, did you see any cases of relapse among these children back into the street life?
About 20%.
20%.
Yeah. And
what was the involvement of probably drugs and substance abuse to these kids moving to the streets?
Substance use, particularly glue inhalants, represent kind of a social belonging among kids who live on the streets. So if you move to the streets and you don't inhale glue, you'll be mocked and picked on by the other kids, and until you conform, that will happen. And so there's this kind of social identification that happens with substance use, and for kids who are looking for a place to belong, they're not going to go to the streets mostly because they want to use substances, but because of other push and pull factors. Sometimes because their friends are there or whatever. But then we found kids are eager to abandon the substance, abandon glue, which they use more because they're hungry, sad, and bored. And so if you help them not be hungry, sad, and bored, but rather to have something that's a meaningful future for them, then they stop using the substances. There's questions about long-term impacts neurologically that I can't answer, but that's the answer for that question.
Thank you so much.
Yes.
Okay, thank you very much, Prof, for this chance and also for the nice presentation. My question would be, in your opinion, what could be the drivers of teenage pregnancy and gender-based violence among the cohorts that you
Yeah, the triple threat. Yeah, teen pregnancy, IPV, intimate partner violence, and HIV. I think, we saw an increase around COVID when people weren't in school. I think hunger, boredom, and sadness or depression, wanting to belong someplace, be seen and visible by someone, likely drive a lot of that. And then, I think when people have choices and information, including like adults and girls and young women, when they have choices and information, they'll generally do things that are helpful for themselves if they're in a good place mentally and socially. So I think economic development is a part of it, and I think education on thinking long term about what do you want your life to become is part of that too.
Okay, thank you very much. I work with the health department, so I invite you for a talk.
Yeah, sure. Accepted. Thank you.
Okay, we will have one more question before we can get to the next presentation. Good. Can I have the microphone? Yeah, thank you very much, Prof. You've said that you've been in this community for the last more than 10 years, and you've involved various communities, 72 in Igembe, and you've been monitoring various socio indicators in terms of the people. Based on what you have found out, have you noticed any behavioral changes, any levels of violence changing within this community, the understanding that could be there among the people, and more importantly, in terms of the street children, do we have low levels of street children now, now that they understand that there are certain things that usually propel these kids to the street? Thank you.
Yeah, thanks. Yeah, we don't have a randomized comparator for the street migration outcome. We only have cohort data. And I wish I could say that subsequent measurements in our data showed that no kids were going to the streets, but that's not the case. It looks like each time we measure, there's a lower percentage of families that report they have a kid on the street, but we don't even have a random comparator to know if that's the case or not. So we need more robust research on that. With respect to parenting and intimate partner relationships, we do have indicators that those improve over time.
Good. Again, thank you very much. Let us again appreciate Professor Goodman for the good presentation. And now ask our Dean to introduce the next key note address. Guest speaker. Please, Dean, go ahead.
Thank you very much, Professor Muchiri, for that well-taken presentation and the organization. Ladies and gentlemen, we hereby wish to welcome and recognize the presence of our next keynote speaker, Professor George Mutwiri. Professor George Mutwiri is a renowned academician, driving from all over Kenya and ending to Canada at the University of Usaski, where he works. The name is so long we might not be able to pronounce it. He is a specialist and a scientist in vaccine and infectious diseases, working with an organization called VIDO. His academic journey spans from 1985. His research areas and interests include vaccines, adjuvants, immunotherapeutic agents, vaccines formulation. He won various grants, and he has been working keenly in the area of public health. He is keen on zoonotic diseases and veterinary medicine also. So, Mamo, you presented a very nice presentation yesterday on ethnobotanical extracts for managing various public health issues. So we welcome you, Prof, to come and give you a presentation and network with our faculty. Thank you.
Let us appreciate him as he comes forward. Okay, before he starts the presentation, again, let me ask all the presenters should deposit their presentations with our IT desk so that they can be downloaded to the computer and we can try and save some time. Please, go ahead. Professor Mamo, you are invited to come and listen to the presentation for this session. Thank you.
Yeah, that's the one. Good afternoon. Good afternoon. Come on. We just had a good lunch. I was expecting something a little more enthusiastic. Good afternoon. Good afternoon. Good. Actually, thank you for the kind introduction, Dr. Kubai. I'm very happy to be here. Meru is home. I was born not very far away from here, somewhere in Kabone. At a different time, I probably would have been a student here, but I'm too old. By the time you're starting the university, I was probably over in Canada doing some stuff. I hope you won't be disappointed. I am not going to talk about vaccines. I am going to talk about something that almost everybody here might play a role. I hope at the end of it, I'm going to call you to action to start doing something. Here we go. What are the greatest threats of our health today? There is no wrong answer. Anybody want to give it a shot? Yes. Geopolitics. Anybody else? Climate change. Anybody else? You'll never get a wrong answer. Ourselves. Anybody else? Weak health systems. Well, we're going to go to that. So the list is endless. My point, I made this after the pandemic. People thought that the biggest threat to our health was the pandemic. Actually, no. We have such big public health problems that we will not be able to win by getting a pill or a treatment. We're going to need to look at this differently. And at the end of the day, we're going to need to change how we think about it. At the end of this, I hope to be able to share with you the context of health in Canada, the challenges we face and why we might change. I'll create some context and hope create some awareness of the complexities of health. And finally, I will share with you my humble proposal on the little we can do to be able to start addressing this enormous challenge. Here we go. Canada has a universal health system, and everybody says it's free. I will not get into that. But everybody, even very educated people, say it's free. They say it's free because they do not have to pay when they get in. There's a long history of it, and it culminates in 1984 when the Parliament passed a federal registration requiring that all Canadians be covered under universal health coverage. And we call that the CHA Act, Canada Health Act of 1984. How many years ago is that? How about the younger people? How long ago is that? So the point is, we have not changed anything for 40 years, over 40 years. And later on, we'll see that the context of health changes over time. CHA is actually primarily about access to health care. Is health care the same as health? I can see Professor Goodman here shaking his head. Because all the good work he was doing, he never talked about treatment. And he's doing some really great work for people. And that is the whole point. So, Canada Health Act is about healthcare. It completely ignores everything else that impacts health. Fast forward. So, having said that, the people of Canada have been served very well by the CHA, or the universal health coverage. Over time, the last several decades, the average life expectancy has increased and now stands at overall 82 years old. And it's a little higher for women, and men is shorter by 4 years. But when we look at the lifespan for adjusted for health, which means how long they live when they are healthy, you can see that Canada falls in the middle of the pack. It is somewhere above US, UK, Germany, and somewhere below countries like Italy, France, Germany. I think whoever did this graph did not want to make Canada look very bad, because if you put the Nordic countries, we're not going to look very good. That's a story for another day. Now, they ask Canadians, what is wrong with your health care? Note, they did not ask them what is wrong with your health. They asked them what is wrong with your health care. Do we have a pointer? No? Okay. You will see that all the questions on the left, they deal with hospitals, drugs, safety, things around hospitals, clinics, and all of that. Except what I have highlighted in red, which is lack of investment in preventive health. There is some appreciation that we don't do enough on the prevention side, but it's not a predominant issue. It's basically overwhelmed by all the other stuff that relates to healthcare. If we keep spending at that rate, we're going to run out of money to cover everybody, and it's not going to increase our health overall. As you can see on the right here is a graph that shows the growth in expenditure as a percentage of GDP. And for the last several decades, it's been increasing with a big blip up during the pandemic. It is estimated that actually in 2024, we are beginning to grow health expenditure faster than the GDP. You can almost imagine what's going to happen if we keep that trend. We spend about $9,000 a year on average for every Canadian, and that keeps increasing, but the health outcomes do not change. In fact, we could double the expenditure, and we will not necessarily double the outcome in health. Where does this money we spend, these lots of money we spend, go? Most of it goes to hospitals, drugs, and salaries for the health professionals that do this. Note that public health, prevention, health promotion, reducing suffering, is a mere 6%. That means that we need to change something. We need to make changes. To quote my friend there, Johnny Van Ad, last century's paradigm of treating disease no longer works because the context of illness has changed. In other words, the 1984 CHA, it almost sounds like SHA, represent needs of that time. At that time, the urgent need was to cover everybody, so that when they get ill, they can go to hospital and be treated, and they don't have to worry about out-of-pocket expenses. That need has been met. However, we still fall short in overall health and well-being, and we'll come to that in a minute. So, what is health and what has changed? You can see a definition there from WHO in 1994, which was about 10 years after the Canada Health Act. And the key message there is health is not absence of disease. Are we together? Okay. Fast forward, only 3 years later, the Institute of Medicine of the United States added something else. The health and well-being has to be a function in the face of changing circumstances. So health is not a constant. What health means is not a constant. It evolves over time. And the context. What health might mean in what Professor Goodman was sharing, even in those sub-counties, might mean something different to different communities. So we need to have that conversation. What health means to us Canadians, and, well, I'm a Kenyan too, so I kind of pull on both sides. So a few things to take note here. Health is not absence of disease. Healthcare is not equal to health. And finally, we need to think of health as a whole, as a system. And I'll get to that in a minute. And these are not my words. The WHO says that many factors combine to determine whether you are healthy or you are not healthy. Okay? And I don't know where we missed the ball here. Which leads us to determinants of health. On my left there. Okay? I don't know what happened. Some of my little circles are moved. But here we have health services. That is where virtually everybody focuses on. Nothing wrong with that. It's just that we're kind of exhausted. Yeah? We've reached a point that even if we invest so much more, there's nothing wrong at all. It served us very well. But we've reached a point that we're going to change the game. We're going to need something different. Okay? To the extent that we're actually ignoring a lot of other factors. You can see there's another 6 domains. Gender determines your health. Education. There's a lot of educated people here. On average, your health is going to be better than somewhere else in the village. That's just how it works. It's not absolute, but it does contribute. Okay? Income and social status. Don't be deceived. I think Professor Goodman alluded to that. Your circumstances, your social circumstances determines a lot what happens to you. Social support, genetics, it goes on and on. In the morning we heard about clean water, drinking water. All those play a role in determining whether you're healthy or not. But WHO goes ahead and tells us that more commonly considered factors such as access to health have less of an impact. Then why do we focus so much on healthcare and health services when we are not going to get as much return as if we played a longer game and paid attention to the other factors? Anybody want to take a guess? They are not real experts on this one. Okay. Yeah? Yeah. And you realize later, we have left this to only a few players. The government, the health professionals, and who else? Who else is a big player? The patients advocate. Who is left out? Who is left out? All of us. Yeah? We pay the taxes. We give them to government. This is the world over. There's no criticism at all to any government. This is just the way it works, and people just keep doing it. Okay? Part of the reason is we've left it to other people to make decisions. And some of the decisions are politically expedient. Others are driven by people like us, researchers. Okay? We're trained to focus on an area, be an expert in it, get grants, do publications, become famous. Individualism. It is not wrong. It's just that we are missing opportunities. Oops. So, we will need what I call a paradigm shift. I like that quote from Albert Einstein. We cannot solve our problems with the same thinking we used when we created them. Currently, in Canada, for example, and it's not that different here, we focus almost exclusively on the illness model. You get sick, you go to the hospital. In Canada, you don't have to pay a dime. So we think we are doing really great. Okay. We largely ignore everything else and just focus on that, free healthcare. But we know it is not sustainable. We will not be able to afford it. Our children and grandchildren are not going to afford it. In any case, it is not smart to keep doing the same thing and expect different results. We're going to need to think about it differently. We need to think of health as a whole. Oops. Okay. No offense, no insult intended, but I thought I would use the metaphor of the 5 blind men. It goes that each of them touches a different part of the elephant and says what it looks like. Let's say what they think it looks like. But none of them can be able to see, to even have a concept of the whole elephant, because each is touching, exposed to only a part of it. If you have those who have the tail, they think it's a rope. Those who have the, anyway, you can see for yourself. It looks like kind of what we are doing with health. Okay? We're just touching on health services and kind of ignore everything else. We need to have that conversation about health as a whole. What does it mean? What do we need to do in the long run to be able to change it? Oops. All right. Because a lot of things are really connected. But we are trained, or we practice looking at them in isolation. For example, and we had that this morning, health and the economy and climate change, just 3 examples, are all interconnected, and they have a great impact on health. But we are trained, the economies look, they have their own experts, they do their thing. People in health do their thing, they have their own expert. And climate change, in fact, in Canada, we have ministries named after that. And each of them have their own expert, their minister, and there are kind of lines drawn. You stick to your work, okay? But they are all interconnected, yeah? We need to start thinking of it as a whole system. Let me ask you this. What is the point of having a Meru level 5 or 6 or 7 hospital when you have so many children on the streets, so many children malnourished, so many children without safe water? You shouldn't just have the hospital. You should have the hospital and make sure that all the other problems or challenges are taken care of, so that health is for everybody. Those children there are not going to need a level 5 hospital. What they need is food and a home. Okay? We need to look at it and the whole system. So, this is what we do know, at least in Canada. Some of the numbers are cancelled. We know it's good. It's decent. But we also know that it needs to be improved. It's not sustainable. We think we need to think about health differently, and we need to make changes. Now, in fact, yesterday. So why aren't we doing those changes? Number 1, it's not easy. Number 2 is how we are configured. Our default Each stick to their line. Our training, yeah? Doctors are trained to make a diagnosis and do the treatment. There's nothing wrong with that, okay? But when you look at overall health, there's something wrong with the model of just expecting treating people is just going to solve all the health problems. That is not a model for the 21st century. Transformation of complex systems like health. You saw how many factors are interplaying to be able to determine the outcome. It is not easy to change that, and I'll get to that in a minute. System transformation is a long game. You have to plan for the future for a long time. That is not consistent with most democracies because elections have a 4 or 5 year cycle. One of the reasons why health services is where the money is put is because there are easy things to count and go and get political mileage out of it. You can put money and add beds in a hospital. That can be counted, okay? You can add doctors and have more patients coming through. A lot of people are getting services. It does not do anything in keeping people from getting to the hospital and maybe saving money, okay? We're going to have to look at this differently. I think I alluded to this before. 3 essential partners in the Canada health system. The easy punching bag is the government, the politicians, because they're the ones who decide how much money is spent where. Then we have the health professionals. They have vested interest there, or you can't blame them. They're fighting for themselves. And the public. And I think the public is where we have not really been, at least in Canada, we are not really engaged in our health, okay? You can get tax credit for renovating your home, but you can't get tax credit for going to a gym. Which one do you think would really save the government a lot of money? Okay. Does it make sense? You're a quiet bunch. Does it make sense? Huh? So why aren't we doing it? Too much, overwhelming, right? We'll see. Okay. So, we do not treat that interplay of determinants of health as a complex system. We kind of take pieces of it as if it's straightforward. It's simple. It is complicated. But we don't take it as a complex system. What we do is we sometimes allocate it as complicated, and then we start treating it as if we do this, we're going to get this. If we do this, if we had beds, we're going to get more patients. Then we can count that. But is that really improving health? We don't ask the hard questions. And then what happens is we keep getting more of the same. Status quo, right? And then in Canada, what we see, we have 2 big political parties, and each comes with promises of bigger investment in health. Because that is easy. You just allocate more money. But we don't really spend time thinking about outcomes of that investment. Because it sticks to only things that you can count to get. I hope I'm not saying anything novel here, but the politicians' priority, number 1 priority, is to be re-elected if they are already in a seat. Nothing wrong with that. It's a job. Yeah? So you do what you have to do to get the job, to get hired. But that has forced us to stay away from a complex system, because it's much more complicated. And what my colleagues there say is that we end up maintaining the status quo, which she refers to as the rigidity trap. Health systems in Canada are very rigid. Yeah? They kind of serve themselves. Each province has their own. If I can use the Kenyan context, each province has jurisdiction on health. It's like it's fully devolved. The federal government just sends them a share of the money, and they decide, according to the Canada Health Act, how to spend it. So then the government is going to decide how they're going to do so that the public, us, can like what we are seeing, and then they can be elected. So we kind of abdicated our responsibility of saying what health really is, okay? And so what these colleagues here are proposing, we need to develop better systems leaders. Not the keyword, systems leaders. And I'll go further and say systems transformational leaders. And that is my proposal today. Now, leaders. Are leaders born or made? Anybody bold enough to take a crack at that? There's no wrong answer. They're what? Keep your answer until the end. Just to give you a clue, every year about $60 billion are spent on leadership development. Big corporations have in-house leadership development programs. Some are outsourced. I bet you have a mechanism for developing leaders in Meru University. Do you? No? That sounds like you're an academic institution. Huh? We recruit leaders based on their technical abilities. Okay? I remember when I first got the first job as Dean of Public Health, Executive Director of Public Health. All they were saying is how many papers I published and how much research I did and grants and all of that. Then when I got in there, I had to do this thing called leadership. It was quite challenging. I ended up developing a training program, a course on leadership in public health. In Canada, leadership is a competency in public health training. But I looked across all schools of public health. They did not have leadership programs in public health. They were outsourcing from the business schools. Then I came across this, Leads in a Caring Environment, because I was looking for a source or a framework that is actually evidence-based. The first thing I did is I Googled leadership and development. Do you want to guess how many hits I got? 6 million. How can you make sense of that? Okay? Leadership is there. Well, almost anybody who served, who in a role, you can write a book and you can write a really good story. But it's also, leadership is also context specific. Leadership in health might be quite different from leadership in business. As a matter of fact, leadership in Meru might be very different from leadership in Garissa or in Kisi or in, you get where I'm going with this, okay? So in public health, in health, if we're gonna make changes, which they found in Canada about 20 years ago, we're gonna need to prepare leaders that can help us navigate this complex system. And LEADS is a framework for developing leadership capabilities for health leaders, specific for health leaders in Canada. And there are certain reasons for that. I don't have a lot of time to go into the details of it. What I'm going to tell you is that it's evidence-based and it's been adopted by virtually all health authorities across Canada. It's still a work in progress. So, in a nutshell, LEADS, represent the 5 domains. Lead self, develop yourself as a leader. There's a whole lot of information on that. Engage others, that's within the organization. Communicate within your organization. Foster the development of your people. Achieve results. The essence of any effective leadership is to achieve results. Otherwise, you won't keep the job. Okay? But you're going to have to strategically align your goals and objectives with the mission and vision of the organization. Develop coalitions. Speaker after speaker here said, this morning said, we do not want to work in silos. It's not different for health. We can't get very far. I think you presented, Professor Goodman presented something very provocative. When we look at an homeless child, we're just looking at the child. But there are other layers of reasons why, including global, that are leading to that. Health is not any different. Leadership is not any different. You need to be able to develop collaborative partnerships across the sector. We will not achieve this by just working as health, just working as experts, okay? And then, the real topic I want to tackle today is systems transformation, because if we have to change something, we're going to change the entire system. It doesn't have to be overall today, but we have to start building steps to get to there, okay? And for you young people, I would encourage you to go and look up on leads. Leadership in the leads context is not hierarchical, it's a distributed model. Anybody can be a leader. You just play a role in influencing an individual or a community in achieving results for the common good of your community, of your society. It doesn't look like I'm inspiring much. Okay, successful leadership, transformational leaders will do some things differently as follows. Systems thinking. This is what we don't get in our education in Canada, and I suspect here in Kenya and many countries. We are trained to do technical things and achieve the results we need and go on. We are not trained, and it's nobody's fault, okay? It's nobody's fault. But we have to change. We have to start what they call kind of thinking outside the box. If you see a result, don't assume it is a cause and effect. It's a linear function. You do this, you get that. Things like health are a lot more complicated. We need to think, a lot more complex. And I'll come to that in a minute. Innovation. And one speaker said in the morning, not only technological innovation. Innovation also means doing things differently to solve a problem. And that is what I am suggesting here. I spent most of my career on vaccine discovery research, okay? Until I figured that you can get a wonderful vaccine and people don't want it. And it works, okay? I was disappointed I was right during COVID. After lecturing for 15 years saying, well, vaccine uptake is a lot more complicated than just working, and my science colleagues were laughing at me. Why do you have to care about that? The point is, human behavior is one of the most challenging obstacles when it comes to innovation. Leaders have to orient themselves to the future. We can't be stuck on yesterday. In fact, not even today. We have to be champions and orchestrate change. It's not easy. Having said that, I just mentioned about human behavior. Culture trumps strategy any day. That because our culture, what we value, who we are, where we live, who we hang around with, what we've been doing for the last, is quite an obstacle. We have to be conversant with that. So, what I keep saying about systems and complexity, what is a system? It's not very hard to imagine. It's It actually consists of what they would call nodes and then connectors. There's a whole subject of systems and systems thinking. We're not going to go into that. Just, I want you to grasp the concept that a system is made of many parts. But what makes a system different, complex, like health, what makes it different from a complicated machine like an engine is that it's not always predictable, okay? And I'll get to that in a minute. The key is the whole is greater than the sum of the parts. As a matter of fact, I would like to even restate that. The whole is different from the parts, okay? It may be greater, but it may also be different from what you're expecting. And it's the key, this is where AI is not going to overtake, because it requires adaptability, okay? AI will overtake a lot of simple, complicated, especially in the medical field. And now I introduce you to a leader's framework for decision making and problem solving. Most situations can be categorized as either simple, complicated, complex, or chaotic. In the interest of time, we'll leave chaotic alone. We know what chaos means, eh? Yeah? Like the terrorist attack on Westgate, that's a chaotic scene. Like emergency room, that's chaotic. Okay? We'll leave that for a minute. Let's pay our attention to simple and complicated. Simple is you have a bacterial infection, and you go to the doctor's office or the office and or hospital, and they give you a an antibiotic. 9 out of 10 times that is resolved. That is simple. The outcome is known. Yeah? Well, sometimes it can get complicated. For example, my eye, I had an inflammation, but the doctor in Canada said, oh, that's pink eye. He gave me an antibiotic. 5 days later, on Monday, it wasn't resolved. I came to Meru on Tuesday. The ophthalmologist said, if this hasn't worked, the situation is complicated. They gave me an anti-inflammatory. It started resolving. That is complicated. But the outcome is known. Yeah? If my eye is no longer swollen, and I can see I'm not reacting right, it means the outcome is known, right? It was complicated. Complex, on the other hand, the middle there, the outcome may actually not be known. And the outcome may not be the answer you want. Okay? Let's try to look a little more at complicated and complex. Complicated, I just described a situation of complicated. But we are trained a lot of times, especially in health sciences or medical specialties, to deal with complicated. Yeah? A lot of times we know what we need to do. The solutions are known. Even if you don't get the results you want, the outcome you want, the kind of solutions are known. Complex, however, you're kind of managing a situation, but you may not get what you may not actually know if the solution exists or not. You have to try, learn, and adopt. And that is why our health systems, our health transformation is challenging. Most governments will not give you funding to go and try things, and you don't know what the answer you're going to get. So, John Evan had their nation say that the health system will not change until we stop acting as if it's complicated. Because people say it covers everybody, Yeah, but covers them badly. So we will need to change. It is complex because focusing on healthcare alone is limiting. Transformation is required. Everybody can be able to play a role. Leadership is a choice. Remember, I said leadership in this context is not hierarchy. It's not whether you are CEO or big wig. No. It is playing a role. Okay? Either individually, in groups, organizations, in government, and so on and so forth. Remember, no one profession, organization, NGO, not even the government alone can achieve this transformation. We're going to all need to get engaged. You're going to find your purpose in your community, in your neighborhood. We have to engage that conversation. Thank you.
Thank you very much, Professor Mutwiri, for the stimulating presentation about our health and the healthcare system. We have a very limited time of asking questions. We have somebody who is online to present our presentation. So if you've got a question, please hold it a little bit and we can forward it to Professor Mutwiri. As for Professor Mutwiri, I know that you are in a hurry. I would ask you kindly to sit in for about 5 minutes. We see if we can be done with this one, okay? And then we can release you. Okay. Thank you, thank you. Yes, bring this one. Again, let us appreciate Professor Mutwiri for the very good presentation that he has given us. I think Mugende, you can connect us to the next presentation. In the booklet, there is a presentation by the name Susan Maynard. That was to be online between 6:15 and 6:30. Not 6, I mean it is 4:15 and 4:30. Please, this is the presentation that we are waiting for. And once she is ready, she can go ahead. And then from there, we'll follow the order of the presentation as it is given in the booklet. I don't know whether, Susan, you can hear us. After Susan gives us the presentation, we'll go back to our lists. So Victor Mweti Marango, you should be ready to give your presentation. And I hope all of you, those who are lined up to present, you have already given your presentation to the ICT team. The other thing which I needed to bring to your attention is that in view of the limited time, we would want you to summarize your presentation as much as possible. Okay, instead of spending 10 minutes, you spend 5 minutes. Okay? Thank you.
Hello, everyone. Can you all hear me?
Yes, Susan, we can all hear you very well. And welcome to this plenary session.
Thank you. Can you all see my screen?
Yes, we can see your screen. You are on the problem.
Yes, I
And
need.
then that is the title slide. So go
let
ahead.
me-
Yeah.
I'm sorry, my computer keeps changing. Let me see. There. Is that better? You can only see one slide now?
Yes.
Okay, thank you. I apologize for this delay and my technical difficulties. So my name is Dr. Susan Maynard. I come to you from the United States, and I'm speaking on collaborative implementation of a standardized transfer protocol engaging stakeholders for change. So the problem that I identified, acute ischemic stroke kills up to 27 million brain cells per minute. And one of the treatments for stroke is a mechanical thrombectomy, and that's manual retrieval of the clot from a brain vessel. Now that procedure is time sensitive, and it requires advanced skills and advanced technologies, and often those things are not available at rural hospitals. And that was the case for my hospital in central Pennsylvania. And so because we did not have that technology for those patients, we had to urgently transfer those patients to tertiary care centers where they could receive that treatment. And so we wanted to get patients in and out of our emergency room as quickly as possible. And so we used this door in, door out time, which is the measure of the time the patient arrives to the emergency room to the time they leave for the other facility. And we wanted that time to be less than 90 minutes. And in 2019, we were not meeting that measure, and we were at 140 minutes. So for this project, I wanted to implement and sustain a standardized transfer protocol in the emergency department. My primary outcome was a door in, door out of less than 90 minutes. My secondary outcome was that the standard process I developed was followed, and the approach I used was a nurse-led quality improvement project. The first step I took was to identify my key stakeholders, and for this, I used every single person I thought of in the emergency department that would be responsible for the transfer of these patients. So I included all of the physicians, all of the nurses. I included the case managers because they were involved in the actual, the phone calls and some of the other pieces of the transfer process. And I involved the radiology technicians because patients had to have CAT scans before they could leave, and so they were involved in the process as well. For my engagement strategy, the first thing I did was look at the current state, and I gathered input from all of the stakeholders on what that current state looked like and whether it was working or not. I then made recommendations for change, but also all of the stakeholders made recommendations for change as well. So as they identified issues, they made recommendations. And then my final strategy was just ongoing consultation. I kept the stakeholders involved throughout the whole process. So I started by doing a fishbone diagram as one of my quality improvement tools to identify the root causes of delays. I then used process mapping to visualize and streamline the workflow, and as a result of that, there were 5 key process changes that were identified and then put into practice as part of the new transfer protocol. I know that this slide is very hard to see, but all of these little yellow and blue sticky notes, they all represent steps in the process. And so this large piece of paper was kept in the emergency department for, I think, about 2 to 3 weeks for all staff, all stakeholders to come up and evaluate and say, well, this piece doesn't work here, or I think this piece needs to go here. And so everyone was involved in this whole evaluation process. For implementation, I identified 2 champions who I could use as informal leaders. I had 1 emergency department physician and 1 nurse, and they were really there to answer questions when I was not available. I trained all of the champions and all of the staff in the new protocol. I trained them individually, but also in groups, so they received training multiple different ways. During the project implementation, fortunately or unfortunately, only 2 patients were transferred, but the mean door-in, door-out time for that was 82 minutes. So the goal of the project was met at that time. And what I wanted to also do was look 3 years after I implemented that and look at, were any of these process changes sustained and how were we doing? So as you recall, there were 5 process changes that were made. And when I looked 3 years later, only 2 process changes were actually still in effect. And the median door-in, door-out time had increased to 110.5 minutes. So it was above the goal of 90. Contributing factors were stakeholder turnover. We had about 1/3 of the nursing staff left the organization and new staff were hired, and it's unknown as to what training they received on the protocol. There were also about 5 new ER physicians who came in, and so I don't know what training they received either. The other interesting thing was that the hospital revised the door-in, door-out goal. So they changed it from less than 90, and they moved the goal to less than 120. Which means they met their goal at 110.5 minutes. I am not sure why that goal was revised. That's something worth looking into. There are some national recommendations that talk about the goal being 90 minutes, but they don't require it for their organizations. So lessons learned, some of the success factors were that I had early and very inclusive stakeholder engagement. I involved as many people in this process as possible. There was informal leadership by the unit champions and ownership of the process. And throughout the entire project, I was very transparent about what was happening. I encouraged collaboration, and I had consistent encouragement of communication. So the challenges I think we identified were that it's very difficult to sustain change over time, and it's important to adapt to these evolving goals and personnel. And some of those things are going to be out of my control, but it's important to learn how to adapt and be flexible. So the recommendations that I had for continuing this were to reevaluate the compliance with the protocol, ask why are people following certain steps and not the others, and then review and align the protocol with current hospital goals. Also, because of the large amount of turnover, it's important to identify and engage new stakeholders. And then lastly, as part of the quality improvement project, I would like to redo the fishbone diagram to look at root causes of delays, and then redo the process map to see if there's anything else that needs to be changed. And these are the references that I had, and I'm going to stop sharing, and thank you very, very much for listening. And I think I heard that there's maybe time for a few questions. I'm not sure.
Thank you very much, Susan. Yes, that was a very good presentation. Let us appreciate Susan for the good presentation. Yes, Susan, we may have a few questions, 1 or 2, which we can take from the audience. Susan, you can hear us?
I can, yes.
Good. We will ask anybody who may be having a comment, a question, to forward it to us. Okay, Susan, you have given us how the transfer period depended on the stakeholders, and you've said on average it was about 82 minutes in one of the situations. I don't know, you also went forward and said that one of the challenges that you noticed was the stakeholders turnover. I don't know how long people usually stay at the same position in wherever you're doing your research, and whether that really affects the transfer period within the services from one facility to another. Thank you.
We have had, in this hospital, there have been some other organizations that have come in, and so I think there's been a little increase in competition, which is, I think, can be a good thing when it comes to healthcare. But as a result of that, some of the staff in this rural hospital have chosen to leave and go work in another rural hospital. And so I think we are, at least in my in my rural area, we are in this constant state of movement and staff looking to go elsewhere, to work with what best suits their family. So staff turnover has been a challenge, not just in the emergency room, but throughout the organization. There are some staff in the emergency room that I believe have been there over 15 to 20 years, but then there are numerous staff who have only started their role within the last year. So it's been a definite challenge.
Maybe having a comment or a question? Yes, you have? Good. Susan, again, let us appreciate Susan for the good presentation which she has shared with us. And Susan, we say thank you very much for sharing that presentation with us. Thank you. Good. I think we can continue. We are really constrained with time. We need to invite our next speaker. That is Victor Marango. Marango is going to share with us part of his work which he has been doing for his PhD thesis. So Marango, go ahead. Spend only 7 minutes. That is 5 minutes of presentation and 2 minutes of comments and questions. You can easily cut down some of the areas like literature review. You get to the introduction, then to the objectives, then to the results, and the discussion. Okay? After Victor, then we should have Daktari Kome coming in for another 7 minutes. Okay? Yes. Check.
Good evening, everyone. My name is Victor Mwiti Marango. I'm privileged to be here today. I'm going to briefly share some of the lessons that we have learned with my supervisors. It was a 15-minute presentation, but Prof has requested me to take 5 minutes. So I'll quickly take 5 minutes to share with you some of the insights that we have learned with my supervisors, Professor Eric Mushiri, Dr. Dorothy Kagendo, and Professor Robert Kay, who is not here with us today. My thesis is on transmission dynamics of a neglected tropical disease known as Kala-Azar. You have heard of Kala-Azar? Visceral leishmaniasis. It's common in the northern parts of our country. So I'm going to quickly share some of the insights, some of the lessons that we have learned in the course of my study. Kala-Azar in Kenya, transmission is documented in 11 of the 47 counties. These counties are mainly in the northern part, in the northeastern, the Rift Valley part of our country, and it's now becoming a public health concern because we are seeing transmission being documented in previously non-endemic counties. What is bringing this? There's a lot of movement of people with their livestock. There's issues to do with climate change. There are also issues to do with our health systems, which are weak. How is my study linked to these themes, these conference themes? What is the contribution? the first part of our theme on innovative research. From all the speeches that have been made, we have learned that research can be used to solve problems in the society. Research, innovative research can empower communities. When we empower communities, when we engage them in solving their own problems, then we'll come up with solutions that are sustainable because the community will own. In our study, we used participatory epidemiology, which is a new approach. It's a new branch in epidemiology that engaged the community in analyzing their problem, what is causing Kala-Azar in Isiolo, what are some of the solutions that can solve this problem, and also engaging the community in implementing the actions. The second part of our theme, Kala-Azar, it's a global challenge. It's one of the NTDs that have been earmarked to be eliminated by the year 2030 by WHO. Kala-Azar affects families, the social-economic status of the affected families because of the high out-of-pocket expenses, the cost of medication, the loss of time that is lost at home taking care of the sick, productivity. Because the disease is common among under 5s, children drop out of school, so there is school dropout, and also there's stigma because of the skin disfiguration that comes along with the disease. So one of the key insights that we learned from our study is that no single discipline, no single actor can address this problem alone. We need to come together, and we need the community to take the front seat so that we can come up with community-driven solutions so that they can own them, they can implement them if they are informed. So that is one key insight. So on the part of surveillance, accurate disease control begins with surveillance. If we get it right with surveillance, then we'll be able to control this NTD. And some of the innovative solutions that we proposed in our study, mobile technology for the community health promoters to aid them in reporting the suspected Kala-Azar cases. We recommended data sharing among the different stakeholders, talked of mapping.
Sorry, please, I have to tell you, you've got only 2 minutes.
Yes, Prof.
2 minutes.
Yes.
You go to the results.
Okay.
Yeah.
Access, when it came to access to treatment, which is a major bottleneck in the country, which is drain the communities from seeking medical care, some of the innovative solutions that we proposed in our study, mobile clinics to enable us to reach the out-of-reach communities. There is telemedicine to connect the communities with the experts who are mainly located in the urban areas. Then there could be innovations on locally produced Kala-Azar drugs so that we can stop relying on imports which are costly and take long to be delivered to the country. When the community is empowered, when you involve the community in analyzing the problem, they will own the problem, and this will boost prevention, treatment uptake, early diagnosis, adherence to the treatment, and also the community will own the prevention that we propose to them. In terms of funding, those are the gaps. Despite the progress that we have made in the country, we rely on external funding, which is declining of rate. There's shift. The donor priorities are shifted. So we need to think of domestic financing so that we can be able to buy the resources that we require to address this disease. So some of the key takeaways from my presentation is innovation must be people-centered. We must involve the community, not as passive recipients, but as co-creators, active engagement of the community. Collaboration is key because we cannot do it alone. We need to understand the context that we are working with so that we don't force issues on the community. We need to work with them so that we can come up with culturally acceptable solutions. Empowered communities is key. When we empower them, they will own the project, they will own the solutions, and it will be sustainable. Then we require strong political will so that we can get the resources, so that we can get the funding. I've talked of donor priorities changing, so we need to rethink on how do we fund our health sector in Kenya. Thank you.
Thank you very much, Victor, for finishing your presentation within time. We are pressed by time. I think what we'll do is that if you have a question or a comment, hang on to it. We will have a short question and answer session so that we can move to the next presentation. And with that, thank you. And let us appreciate Victor again for the good presentation that he has done. Next, to share his results with us is Dr. Geoffrey Mudhuri Kome, who is a senior director of public health in county government, but also a student here. And he is going to talk about assessment of factors influencing outcome of a drug-resistant tuberculosis treatment among patients enrolled in Meru County, Kenya. So, Mudhuri, welcome. And in view of the time, I've consulted the chair lady of the department, or the chairperson of the department, and we have decided the last 4 presentations, because they are proposals. Those last 4 presentations can be presented tomorrow morning. Would you agree with me? Good. You know, when I'm with the chair, I don't fear much. So the chair says, in view of having no time, the presentation by Esther Wanjiru Karanja, good, more better results, because Dr. is saying he is going to share with us the proposal, meaning that we can save some time and we can see how we can accommodate some of the far-coming students to do the presentation. I could see Esther was looking at me very badly. Esther, you know you have been my friend all through, okay? Dr. go ahead. You've got 7 minutes.
Thank you, Prof. Good afternoon, everyone. Yeah, my name is Kome Mudhuri. As Prof has said, I serve as the County Director Health, Meru County. And I'm excited to be here to present to you a snippet of my proposal, which is titled Assessment of Factors Influencing Outcome of Drug-Resistant Tuberculosis Treatment among patients enrolled in Meru County, Kenya. So for our students, have we heard of TB? Drug-resistant TB? And drug-sensitive, yeah? Okay. So what we are saying, DRTB is a condition of public health concern. There are quite a number of reasons. One, it's a form of antimicrobial resistance. And in some quarters, they are saying antimicrobial resistance is actually the next pandemic that is coming. And for this, when that happens, then that leads to us having fewer treatment options and increase in mortality. And that is what we don't want. Just to give you a global perspective, in the year 2023, 175,923 cases of DRTB were notified. And for Kenya, the current numbers that we report are usually lower because according to a survey that was done in 2016, it showed us that we are missing around 40% of the cases. And specifically for Meru, in the year 2022, we reported a total of 110 cases, and we were top in the country. So just as our one of our keynote speakers said, health is complex. So the same for DRTB management. It really takes a lot to ensure that we get good outcomes. And as you can see, the trend globally and even in Kenya, we just attain around 60% as opposed to the target of 90% and above. These are now the favorable outcomes of DRTB management. For Meru, we are trying, we are at around 75% treatment success rate, but still there are challenges because you can see there are deaths being reported and loss to follow up. And you know, these are people, these are human beings we are talking about. So what do we want to achieve is mainly to provide insights into the factors that are influencing the outcome of DRTB treatment. As you have seen, Meru County is among the high TB burden counties in Kenya. As part of the end TB strategy, then treatment outcome monitoring becomes very key so that we make sure that we attain the targets of 90% case detection and 90% treatment success rate and above. The research objectives, the broad objective is to assess the factors influencing the outcome of DRTB management. Specifically, we'll be looking at patient characteristics. We'll also be looking at clinical factors. We'll also be looking at health service delivery factors. I will explain this more in detail in the next slide, which demonstrates the conceptual framework. So for patient characteristics, we will be looking at things like, or factors like gender, age, occupation. For clinical factors, we'll be looking at the resistant pattern. Is it monoresistant? Is it multi-drug? Comorbidities, nutrition status. For health service delivery factors, we'll be looking at issues like model of care, the composition of the clinical review meetings, monitoring, the laboratory work in monitoring, and the combination of all these factors will be trying to relate them with the outcome of the treatment. And the outcome can be in two ways, either favorable, that is, the client is either cured, or at least has completed treatment, or unfavorable, where we have loss to follow-up, deaths, and treatment failure. Methodology will be a retrospective cohort study design. We'll be looking back into the records of patients who have been served within our facilities between January 2020 and December 2023. We shall use a structure and data collection tool, after which we shall input that data into a statistical package for social sciences, version 28. And then I sent this a proposal, so there are no results. Yeah. So the statistical significance of associations will be interpreted using the chi-square test statistics, and the main use or the main significance of this study is that the findings will be key in informing policy and practices aiming at improving quality of care. So maybe lastly, I think as I close, some medical considerations. We are going to seek approvals from the listed institutions. That is the Meru University Science and Technology, Institutional Research and Ethics Review Committee, and also NACOSTI. And then we will come up with modalities of ensuring there's confidentiality and data security. Yeah, I think that's it. Thank you.
The next presenter, please.
Good evening. My study is on prevalence of hypertension amongst the young adults attending Meru Teaching and Referral Hospital in Kenya. My supervisors are Dr. Kiboi and Dr. Mushiri at Chuka University. That's where I'm a student. So hypertension is a sustained high blood pressure that is above, that is at 140 over 90 millimeters of mercury or above, or patients on antihypertensive drugs. It can be identified in the community via screening of the blood pressure or patients in the hospital setup. So it is associated with a high mortality rate, and this is as a result of some of the complications, mostly the cardiac complications or cardiovascular complications. It has been known from the studies that it is a condition mostly in the high earning income countries, but from the statistics, it is increasing in level from the low and medium income countries, and mostly in the sub-Saharan Africa. It is an uncommunicable disease of global concern at 1.2 million in the population, The World Health Organization approximates 46% of the over 25 years old to be having hypertension. So most of the studies have focused on the elderly, and there's scanty information in this age group of the young adults between 18 and 35 years of age. So my objective is to determine the prevalence of hypertension and associated factors among the young adults at Meru Teaching and Referral Hospital. So the study took place at Meru Teaching and Referral Hospital. The design is analytical cross-sectional design. Validity was ensured by my experts, and test-risk test technique. Sampling technique is systematic sampling technique. Data collection was via a researcher-administered structured questionnaire. Data analysis via statistical package of social sciences, version 29, in vivo, version 14, descriptive statistics, chi-square test, and logistical regression were used. Data presentation is via graphs, descriptive narratives. So ethical consideration was observed, whereby I sought an ethical clearance from Chuka University Ethical Committee. From Meru County, I sought authorization from the Ethical Committee, and again, NACOSTI gave a license for the same. I also sought consent from my respondents. So the findings, my sample size was at 281, with the majority of the respondents being female in the respondents list. At 182, the age, the number of age, it was between 30 to 35 years of the respondents at 99. Those who are married were majority at 143. A larger proportion of the participants had attained secondary school level of education. On occupation, majority were running their own business, small businesses at 96. And gross income, majority were earning less than 10,000 shillings. So on prevalence of hypertension, for diastolic blood pressure, majority were at 50 to 90 millimeters of mercury, and the systolic blood pressure, majority of them were at 80 to 140 millimeters of mercury. This is the graphical presentation of the prevalence, whereby the prevalence of hypertension among the young adults in Meru in Meru County is at 13.2, which is a bit lower than the national statistic, which is at 22.4. This is just a repetition of whatever. So this is one of the objectives that I'm presenting, but I had 4 of them. The other associated factors, like dietary factors, and as we can see, fruit consumption and vegetable consumption is one of the factors that is associated with hypertension. For those who are consuming more fruits in a week, like more than 3 times, they were having, they never had hypertension as a diagnosis as compared to the others. So again, lifestyle characteristics contribute, had some, was one of my objectives. And when we talk of this, we are talking of alcohol intake that was associated with hypertension. In the conclusion, as I had indicated, 13.2% of the respondents had hypertension, and this was in comparison with a study that was done in Tanzania in support that indeed fruit intake and vegetable intake play a role in prevention of hypertension. So onto my recommendation into policy, I recommend that there be a consideration of policy revision to give insight to aid in ensuring blood pressure that is controlled. And how can we do this? It is by ensuring that there is blood pressure screening to every patient who comes to the outpatient. Again, on practice, recommend that the health care provider provide awareness creation to the patients who come to the outpatient on the importance of consumption of vegetable fruits, and indeed reduction or total elimination of raw salt consumption, which is a contributor of hypertension. Thank you.
Okay, thank you. Let us appreciate Rebecca for the good presentation. Rebecca, you get time? Yes. Next on the line. Okay, I think we can ask you to sit down a little bit. Easy.
Are you ready?
Yes.
Is yours a proposal or results? We can give him because
He has got.
yeah, framework. Let him give us. Then you'll follow him, please. Sorry.
He's got your. It is which one? Joe Mapesa.
Okay, good evening.
Good evening to you, Job.
Sorry, my name is Hilary Kibiriti.
Hilary Kibiriti. Okay. Go ahead. Yes, sir, you've got about 7 minutes.
Thank you, Prof.
Yes.
I'm Hilary Kibiriti, presenting an explanatory model for health system responsiveness among chronic care. I would like to appreciate my co-authors, Professor Wanjat Nambagen, VC Academics, Riara University, and Dr. Job Mapesa, Senior Lecturer, KEMU. Health system responsiveness reflects meeting people's non-medical expectations. It builds trust, it improves care seeking. WHO dichotomized it into two facets: person-centric domains, being dignity, autonomy, communication, and confidentiality, and client orientation domains being prompt care, amenities and support, social support and choice. In chronic care, it has been noted that respectful interactions affect adherence and trust. Because the setting is chronic care, particularly diabetes and hypertension, we notice they are on the increase. Globally, about 10% of the population afflicted with diabetes, and in Kenya, between 2 to 5%. Hypertension affecting globally about 22%, and in Kenya as high as 45% reported, other areas 25%, driven by urbanization, aging, lifestyle, poor diet, and stress. In respect of responsiveness, which is the theme, Kenya had ranked poorly, and there are a number of expositions about unresponsive care, including rape incidents in the hospital, unresponsive care dampening adherence to diabetes treatment, and reports of abuse, discrimination, and breaches of confidentiality. Yet we lack limited data on the predictors and this lack of a guiding framework that is context specific. And that is why we aimed to propose an explanatory framework for health system responsiveness informed by theory and real-world data. We believe the model will be useful in guiding quality improvement interventions and guide investment efforts. How we went about it combined review of literature and empirical findings from a quasi-experimental mixed method study involving a baseline, training, and endline at 3 sites in Kenya: Kimilili, Gatundu, and Uasin Gishu, with a sample size of 323 clients either having diabetes, hypertension, or both. 6 focus group discussions, 3 with health workers, and 3 with clients, and key informant interviews with unit managers in the 3 facilities. The review of literature helped us get the predictors and the frameworks for responsiveness. And the predictors, as reflected in the conceptual framework, included responsiveness valuations, accountability mechanisms, access factors, structural factors, organizational culture, and justice perceptions, leading to responsiveness. Empirical analysis, descriptive, all were rated on 5-point Likert scale, with 1 being the worst and 5 the best. Scores summed and dichotomized into favorable or unfavorable, using the demarcation threshold formula. So literature findings in terms of the existing frameworks, we have the WHO that gave us the original 7 domains, and the 3 scholars that followed, Lecovia, Jeru, and Fruzan, each contributed more domains, including communication, effective care, attention and access, trust, and coordination. Then in 2011, Robon proposed environmental ring to responsiveness. 2016, Valentin and Bossel alluded to social determinants, perspective on responsiveness. 2017, Mizev and Ken posited responsiveness as a dynamic process involving actors' expectations and processes. And lastly, Khan, who positioned responsiveness as feedback involving interface between government and the clients. In terms of empirical findings, social demographic characteristics at the baseline, 5 of them were significantly associated with responsiveness, they being facility, medical condition, religion, marital status, and income source. While at endline, only 2 retained significant association, being marital status and income source. So the next step was to a binary logistic regression modeling, which gave us 4 factors that remained significant influencers, being accountability mechanisms, structural factors, organizational culture, justice perceptions, with an aggregate R squared of 0.32 suggesting a moderate relationship, a model being able to predict 70.5% overall effectively. Factoring the social demographics that was significant at endline improved the prediction model, the power of prediction to 40.4%, suggesting that these marital status and occupational, the occupation can moderate the effects. Themes from the qualitative analysis are as follows. Responsiveness is valid generally. More respect for persons' domains have more traction than the client orientation ones. Perceptions for performance are heterogeneous. The context counts, and the challenges that emerged include 1, low client voice, low managerial support, limited resources, limited regard for accountability mechanisms like service charters. On that basis, we proposed an explanatory framework that positions responsiveness as an outcome impacted upon by issues at 3 levels. The first being the context, issues to do with the health policies, resources, social, cultural, and geographical settings. And the second layer being the specific drivers, which were the predictors that we found in literature and in the empirical modeling. Working through the interaction between a client and a healthcare provider. When we look at a client, we would want to ask how activated, how engaged, and how empowered are they? And this has implication from their social demographic background. And when you look at the healthcare provider, we would want to ask how competent, how empowered, and how very clarified are they? And this has implication from their training and capacity building. So that is the proposed framework for health system responsiveness. The limitations, literature was only from the English sources. The data was from primary hospitals, limited to diabetes mellitus and hypertension, and therefore it might not apply in other contexts. In conclusion, we have proposed a framework showing responsiveness shaped by 3 factors: context, drivers, and actors. And we recommend deliberate investments in policy to reflect these factors. Thank you.
Thank you very much, Hilary, for that good presentation. Let us appreciate him again for the quick presentation that he has given us. I think anybody who may be having a question? Good. Hilary, my only question is this. Your responsiveness framework, the outcome had a lot of variables. Wouldn't you think that those many variables would have an effect on the responsiveness as you would have wanted to describe it?
Thank you, Prof. Those variables were actually created in the year 2000 by World Health Organization as the indicators of responsiveness, and they are the same ones that other scholars have built on them. But when we are scoring, we do a metric so that we can sum and get a composite value. Thank you.
I think with that we can move on to our much awaited Ben presentation. Ben, sorry for telling you to hold on a little bit. Okay?
It's okay, Professor.
You can go ahead now, Ben.
Thank you, thank you.
You have 5 minutes.
Yes.
Yes, to share with us your proposal.
Good evening, everybody. Benedict Natuwake from Marsabit County. Before you, I present a determinant of severe acute malnutrition among children 6 to 59 months. Severe acute malnutrition is a serious life-threatening condition, occurs mainly on 6 to 59 children. This is due to nutrition deficiencies or low supply of the micronutrient to the body system. In Marsabit County, as one of the asshole county, is mostly affected, is facing a huge high rate of severe acute malnutrition in the regions, mainly because of food insecurity, low access to the health facilities, and low knowledge on nutrition aspects to achieve the optimal nutrition. The study objective is the determinant of severe acute malnutrition among that cohort, that is 6 to 9 children in Marsabit County. The study is to be conducted in Laisami sub-county. Marsabit has 4 sub-counties. Laisami is one of the county with the high rate of severe malnutrition, with the high gum rate, in as far as the county is concerned. The research decides to adapt cross-sectional design to gather data at a single point in the region. This approach will help to identify the risk factors associated with severe acute malnutrition in the region. The sampling data, size 385 respondents, determine causing the current sampling. Simple random sampling and purposive sampling will be used with the structured questionnaire as well as key informant interview. Data analysis. Data will be cleaned, coded, and analyzed using the SPSS version 28. All this regression will be used to examine the relationship between the variables. The study aimed to create awareness on the factors associated with severe acute malnutrition and empowering the community on how to address those factors. The finding as well, data will empower the community on to design or come up with the best nutrition interventions to address the condition. Result will contribute as well academically on making viable decisions, especially on to design the best intervention to address the severe acute malnutrition at the community level. Thank you.
Thank you very much, Ben, for saving us those few minutes. Again, let us appreciate Ben for the good presentation. Yep. Next is Esther Karanja, who is going to share with us our proposal for master's degree. Karanja, welcome.
So, good evening. My name is Esther Karanja. My co-author is Dr. Patrick Kubai and Dr. Mary Amatu. My topic is risk associated with malnutrition in children below 5 years in Kajiado East and North Sub-Counties, Kajiado County, Kenya. My presentation outline is we'll have introduction, objectives, problem statement, justification, conceptual framework, and methodology. On introduction, malnutrition is a deficiency, excess, or imbalance in person nutrient intake. And for this study, the study will concentrate on undernutrition. Poor feeding practices lack adherence to exclusive breastfeeding have been identified as the primary cause of high malnutrition levels. Globally, 44% infants are exclusively breastfed with some optimal complementary feeding practice being widespread, contributing to stunting, wasting, and underweight. In Africa, the number of children under 5 are affected by stunting, and since 2000, the cases have been increasing, and it is projected by 2025 the number of malnourished child will be 61.4 million. In Kenya, malnutrition contributes to nearly half of deaths and infants and children under 5, and also worsening preventable conditions like diarrhea, pneumonia, and newborn complications. In the study area that is Kajiado, according to a SMART survey that was conducted in 2018, the cases of stunting were at 25.3%. Stunting was at 93%, and underweight was at 22.5%. On problem statement, despite Kenya having strategies to combat malnutrition, Kajiado continues report cases of high malnutrition. And some of these strategies are like Kenya National Action, Kenya Nutrition Action Plan. Also, Kajiado have Kajiado County Nutrition Action Plan. And despite having all these strategies, we still record high cases of malnutrition. On justification, the Kenya Constitution recognizes adequate food and nutrition as a fundamental human right, as highlighted in Article 43, and affirms every child right to basic nutrition as highlighted in Article 53. In Kajiado, where the study will be carried out, the cases of malnutrition admissions have tripled since 2020 to almost have tripled from 1495 to 4197. Thus, this study will examine the local risk factors to create effective casserole appropriate solution. It will also add knowledge about malnutrition in pastoralist and semi-arid areas, offering useful insight for other arid regions in Kenya. The study objectives, broad objective is to determine the risk factors associated with malnutrition in children under 5 in Kajiado North and East Sub-County, Kajiado County, Kenya. Specific objective, number 1, it will establish the nutritional status of children under 5. 2, identify socioeconomic factors associated with malnutrition. And 3, to assess the feeding practices that may be associated with malnutrition. And 4, to evaluate morbidity associated with malnutrition. On conceptual framework, the independent variables will be socio-demographic characteristics, which will be age, level of education, marital status, income, occupation, place of residence, and also parity. On nutritional status, we look at stunting, wasting, and underweight. Feeding practices, the study will look into exclusive breastfeeding, complementary feeding, and nutrition education for caregivers. On morbidity, the study will look into immunization status, vitamin A supplementation, deworming, and water safety. The methodology, the study design will be a descriptive cross-sectional design will be used. The study site will be Kajiado North and Kajiado East sub-counties in Kajiado County. Study population will be carried out among caregivers with children aged below 5 years. And the sample size, the Fishers et al. Formula will be used. Sampling techniques, 2 facilities in the 2 sub-counties will be sampled. That is those with the highest MCH workload. And the sample size will be distributed in proportion to workload. Data collection tools, survey data will be collected using questionnaires with both closed and open-ended questionnaires. And a pretest will be done in the neighboring sub-county, that is Kajiado West. Ethical consideration, study proposal will be presented to faculty examiners before the Meru University of Science and Technology Ethical Review Committee for scientific review. Then permit will be obtained from NACOSTI, and data collection authority will be sought from Department of Health Services, Kajiado County. Also, informed consent will be sought from the study participant. Thank you.
Thank you very much, Esther, for the quick presentation that you've shared with us. I think, Esther, before we get to the next presentation, if you look at your objectives and your title, they are not aligned you need to go back and work on your title indicates malnutrition. When it gets to your objectives, you're talking of nutritional status. Those do not go together. Okay? So you need to go back to the drawing board. Either you align your objectives to your title and get to know what are those measurable variables that you can build from at objective level. Okay? Yes. Yes, Dr. Adomi, yes? We have one of our guest epidemiologists in the house, Dr. Karoni.
Okay, thanks Esther and Ben for your presentations. Mine is just an observation like Dr. Mushiri has said. I think you have said malnutrition, but it needs to be undernutrition because even obesity is malnutrition. So I think it needs to be a bit specific, your topic and your objectives. Maybe just focus on undernutrition. And then for both of you, I'm just wondering from literature, what are the gaps that you are trying to fill in your studies? Because documentation of causes of severe acute malnutrition, risk factors for malnutrition are widely documented. So is it that your study setting is different and will give us different risk factors? Sort of look, what gaps are you trying to fill that is not documented in the literature as far as your topics are concerned?
Noted.
The other thing which you need to look at there will be a build-up of information necessary for you to answer the questions that you've got. You really need to go back and work with your supervisors so that they can be able to guide you properly. And when you say to evaluate morbidity, you must think of what base are you going to be using. Okay? Those will put you into a lot of trouble. Okay, I think with that, we can move to the next presentation. I don't need you to respond to that, but take note of that. Galgalo is going to be next. Galgalo, you've got 5 minutes or 7 minutes before we can call Cleopas. Cleopas, your prayers are heard.
So good evening. Sabla Galgalo is my name, and this is my presentation for my proposal. My topic is factors influencing HPV vaccination uptake among caregivers of adolescent girls in pastoralist community of Garbatula Sub-County, Isiolo County, Kenya. My supervisors are Mary Joy Kaimuru and Dr. Jane Ruto. So my background is the prevalence of infection with high risk human papilloma virus among Kenya is rising, posing a public health concern as it is reflected on increased cases of cervical cancer. As a key prevention strategy against cervical cancer, the World Health Organization therefore has recommended the vaccination of all girls who are aged between 9 to 14 years before their kotache, that is before they get indulged in sexual intercourse. Kenya has already integrated the vaccination of school-age girls 9 to 14 years old into routine immunization schedule. However, the coverage is still low. Country, particularly among hard-to-reach areas, populations such as nobody pastoralist communities, for example, in Garbatula Sub-County, which is in Isiolo County, Kenya. This study aimed to investigate the factors influencing HPV vaccination uptake among age-eligible girls in pastoralist community of Garbatula, Isiolo County. The objective of the research is to investigate the factors influencing human papillomavirus vaccination uptake among caregivers of adolescent girls aged 10 to 14 years in the pastoralist community of Garbatula, Isiolo County, Kenya. The justification of the research is this study will going to help to examine issues or challenges around access and attitude to human papillomavirus vaccine uptake in hard-to-reach communities, that is pastoralist communities with poor health-seeking behaviors, and also representing population that may be difficult to reach for an adolescent, pre-adolescent health interventions for a number of reasons, including mobility, difficult access communities to offer services, availability to receive vaccine, school absenteeism and dropout, and early age and marriage. Research questions: what is the rate of HPV vaccines uptake among adolescent girls aged 10 to 14 years in pastoralist community of Garbatula, Isiolo County, Kenya? How is the knowledge of caregivers of adolescent girls aged 10 to 14 years towards on HPV and HPV vaccination in the pastoralist community of Garbatula in Isiolo County? What are the perceptions and attitude to caregivers of adolescent girls aged 10 to 14 years towards HPV and HPV vaccination in pastoralist community of Garbatula? What are the factors influencing human papilloma virus, that is vaccination uptake among caregivers of adolescent girls aged 10 to 14 years in pastoralist community of Garbatula, which is in Isiolo County? The methodology that we're going to use is a mixed methods, cross-sectional study, analytical design that will be employed on a sample size of 347 caregivers with adolescent girls aged 15 to 18 years. This because the adolescent girls who are 15 to 18 years are the girls who have completely finalized the dose, the first dose and the second dose of HPV vaccines. Therefore, quantitative data will be collected using a structured questionnaire administered by the research team, while qualitative data will be therefore collected with the aid of focus group discussions and key informative interview guides. Pretesting will be done where 10% of the sample size in Serich ward will be targeted. Therefore, SPSS version 27 will be utilized for data analysis. Descriptive statistics will be presented using frequencies and percentage for categorical data and a mean and median for continuous data. Chi-square test will be used to test association between categorical variables and binary logistic regression to determine the predictor variables for vaccination uptake. Thematic contents analysis will be used to qualitative data findings will be presented using tables and charts, and the expected results will be find factors that influence HPV vaccination uptake among adolescent girls, that is perception, attitude, knowledge towards HPV vaccination uptake, and understanding of children vaccination status. As a requirement, EDICO approval will be sought from Meru University EDICO Review Committee. Research approval will be sought from the Meru Graduate School, where research permit will be sought from NACOST. Keyword in my research is one, vaccines, HPV vaccines, Kotache, cervical cancer, pastoralist community. Thank you.
Thank you very much, Sabla Galgal, for the quick presentation that you've given us. I think I open for anybody to have a comment or question. Yes, Dr. Kibiriti? Hilary, yes.
Okay, just a quick one. You are sampling on health workers. I could see something like on 347 health workers, yet you are looking at factors for uptake. Kindly clarify.
So, I think it's not health workers. That one, 347. Yes, that is caregivers, not healthcare workers. Thank you. Any question?
Good. I think these are in the formative stages, these proposals. We will have to look at them deeper and see to it that they fulfill what would give our student measurable results. Okay? So, Galugalo, thank you very much. Work with your supervisors to make sure you improve on the proposal. Okay? And at the moment you use 15 to 18, you've cut off gender, you've cut off age in the analysis. So there are a number of things that you need to look at your proposal. Okay? Good. Just to finalize this session, we're going to have 2 more proposal presentation. The first one is going to be done by Kadurima. Kadurima is going to give us a presentation or proposal on assessment of water quality and associated health risks in Bori East Sub-County, Meru County. Kadurima, the floor is yours.
All protocols observed, good evening. My name is Joseph Kadorima Moite. My co-authors are Dr. Jane Ruto and Dr. Ananias Nkonge. I was doing a title on assessment of water quality and its effects on human health in Ruire Ruarera, in Bore East Sub-County. The topic, the title is measuring well with our theme today. You can't have a sustainable riverlands without an healthy community, and you can't empower the community without checking if they are taking the right diet, if they are taking the right thing that is not having poor quality. Water quality includes physical, chemical, and biological characteristics based on its standards of its usage. And it impacts both the public health and the aesthetic consumable products. The area of study has an area of 251 kilometers squared and 23,834 households that will be sampled. The main source of drinking water in the area of study includes the wells, springs, aquifers, rainwater, among others. The research has not been done before in the study area. Therefore, this will be important for policymakers, especially by the county government of Meru. My main objective was to assess water quality and the associated health risk in the area of study. And the specific objectives were to establish the biological, the chemical, pollutants, and the methods that the residents use to treat water, and also to assess the water-related diseases that are common by the residents of the area of study. The research, as I said, will close the gaps by discovering the health risk that are associated with water in the area of study. The water samples will be collected from the field of study and will be analyzed in laboratory to identify and quantify different pollutants, both microbiological and chemical pollutants. Quantitative data will be collected using a structured, open and cross-headed questionnaire. The data from the laboratory will be analyzed using the SPSS version 26. The result will be presented in percentages, tables, charts to show the correlation between the water usage and its quality. The expected results will be detailed analysis of water content and the retrospective data on water-related diseases from the area of study. This study will help the county government and other stakeholders to intervene on matters of water hygiene and water sources that is supplied within the area of study. And this is the end of my presentation. Thank you.
Thank you very much, Kathurima, Joseph, for that quick presentation. You've just shared with us the objectives, the title, and I hope that you'll be filling in other sections so that you can make it a better proposal. However, one issue which has come out, you've said you want to assess water quality. But I would think the best action verb would be to evaluate water quality, because there are standards. Okay? There are standards. So you need to go back, work with your supervisors in terms of how you can make better objectives. Okay? Now, finally, we call upon Cleopas, Kimathi, Mbogo to come and give us his proposal. And eventually, I think that would be the final proposal. Okay.
Good evening. Yeah, my name is Cleophas Mbogo. I'm a medical laboratory technologist by profession, and I'm a master's student in epidemiology. I'll be presenting my proposal. The topic is the prevalence and factors associated with multidrug-resistant E. coli causing UTI among women seeking services in Nyambene and Meru Level 5 hospitals. My supervisors are Dr. Kagendo and Dr. Patrick Kubai. So there have been several presentations about the multi-drug resistance, and E. coli multi-drug resistance is a major challenge globally, causing about 70% of all infections among women. So the global prevalence of multi-drug resistance is between 3 to 88%, depending on the geographical region. So the study will be conducted in Meru Level 5 Hospital and Nyambene Sub-County Hospital between July 2025 and October 2025. Purposive sampling will be done among women who be suspected to be having symptoms of UTI. So the statement problem: drug resistance is a major health challenge in the management of UTI. Patients suffering from UTI are more likely to spend more days in hospitals, which increases the cost of healthcare and into healthcare complications, and also increases the rate of morbidity and mortality rate. 27% of women are at risk of suffering from recurrent UTI. Women suffering from UTI are 2.7 risk of developing recurrence within a span of 6 months. There are also conditions like septicemia, which are common when a patient is suffering from drug-resistant UTI, and they also increase the risk of morbidity and mortality among patients, especially among immunocompromised patients. So the study justification: so there is lack of data on the preference and the factors associated on multi-drug-resistant UTI among women in Meru County. The MDR is a global health concern due to the increased cost of healthcare and increased mortality and morbidity rate among affected patients. The study will address the knowledge gap in the preference and factors associated with multi-drug-resistant UTI. Study will help to come up with evidence-based guidelines for the management of multi-drug-resistant UTI. And the study will help to come up with public health guidelines to combat multi-drug-resistant UTIs. The first research question is, what is the prevalence of E. coli infections among women seeking healthcare services in Meru Level 5 and Nyambene hospitals? What is the difference in terms of antibiotic susceptibility patterns in E. coli isolated among female patients in both facilities? What is the risk factors associated with antibiotic-resistant E. coli causing urinary tract infection among women seeking services in both facilities? What are the factors contributing to the emergence and spread of drug-resistant UTI among women with urinary tract infections? The first objective will be to determine the preference of E. coli drug-resistant UTI among women seeking services in both facilities, to compare the susceptibility pattern among women seeking healthcare services in both facilities, to evaluate the risk factors associated with multi-drug-resistant E. coli infection, and the fourth objective will be to examine the factors contributing to the emergence and the spread of multi-drug-resistant UTI among women seeking services in both facilities. So the study area will be Meru Level 5 and Nyambene Sub-County Hospital. Study population will be adult women seeking services in both facilities. The sampling method that will be used to purposive sampling. Patients will be given consent forms so that they can agree to participate in the study. Questionnaires will be administered to help identify the risk factors. Patients will be given containers to collect midstream urine. Culture will be done using CLED, McConkey, and Miller-Hinton agar for sensitivity. So the dipstick urine will be done first, and those positive for nitrate and leukocytes will be done culture. The medias used will be CLED, blood agar, McConkey, and Miller-Hinton. Bacteria identification will be done using biochemical tests such as catalase, indo, and coagulase. The Fisher method will be used for the sample size calculation, and it is 288 participants. The inclusion method will be those included will be the adult women seeking services in the facilities, and those will be suspected to be having urinary tract infection. The study will not include patients who are under the age of 18 years. The data analysis, so descriptive statistics will be used in the preference calculation. Comparative testing will be done using chi-square test to assess the association between MDR E. coli factor and factors like age, history of antibiotic, and history of UTI. Multivariate logistic regression will be used to identify the dependent risk factors for MDR E. coli by adjusting the confounders such as comorbidities and hospital settings. Antimicrobial susceptibility profiling will be done using resistance patterns that will classify the isolate using standardized guidelines present resistance rate via heat maps, bar charts, or phenotype frequency that will write the predominant resistant combination. So the data analysis will be done using SPSS. For regression modeling and data visualization will be done using Excel for trends and demographic charts. Thank you. That is the end of my presentation.
Thank you very much, Cleopas, for that presentation. Anybody who may be having a comment, a question to direct to Cleopas? Cleopas, I realize you have said that you are going to determine the prevalence, and you are going to use those who are positive in order for you to do the culture, isn't it? Yes. How will you determine the prevalence?
The main aim is determining the preference of the E. coli drug resistant, not generally the preference itself.
Okay. I think you need to make sure that it comes out clearly what you'll be looking for. Otherwise, you might generate some results which are not necessarily what you want. The second thing I realize in one of your objectives, you have said that you are going